Okay, good evening, everyone. I'd like to welcome everyone to our MSIG webinar, Adaptive Sports Paralympic Team Physicians. This is the second webinar of a two-part series on adaptive sports. We're so honored to feature four speakers today who will share their expertise on adaptive sports and their journey and role as a Paralympic team physician in their specific sport. Dr. Michael Uihlein, Dr. Kyle Nagle, Dr. Stephanie Tao, and Dr. Irfan M. Asif. My name is Ushijima, and I'll be serving as the moderator for tonight's webinar. I am one of the AMSSM MSIG officers, and I've been serving this year as the AMSSM MSIG Secretary. I'm a current fourth year at the University of Hawaii Medical School, John A. Burns School of Medicine in Honolulu, Hawaii. And I am going to be applying into internal medicine, but still not sure about what kind of future career I'll be doing after that. So after all four speakers have finished with their presentations, I will serve as the moderator for a Q&A segment. During the webinar, please feel free to enter any questions you might have into the chat, and then afterwards, after all the presentations during the Q&A, I'll ask each question entered in the chat, and our speakers will have the chance to respond to each question. Okay, so now it's my pleasure to introduce our first speaker, Dr. Michael Uihlein. Dr. Michael Uihlein is the assistant professor in the Department of Emergency Medicine at the Medical College of Wisconsin and is currently the Associate Chief of Emergency Medicine for Education and co-director of the Adaptive Sports Medicine Clinic at the Clement J. Zablocki VA Medicine in Milwaukee, Wisconsin. He completed his sports medicine fellowship at the Medical College of Wisconsin in 2016 and has been the team physician for the U.S. National Para Ice Hockey team since 2012. His experience with adaptive sports and caring for disabled athletes includes the Paralympics in 2014, 2018, and 2022 in Beijing, China. He still is part of the national medical team for the National Veterans Wheelchair Games and has provided coverage at the National Disabled Veteran Winter Sports Clinic and the National Veterans Golden Age Games. He helped found the Wisconsin Adaptive Sports Association Admiral Sled hockey team during his fellowship and is a co-editor of the book Concussion Management of Wheelchair Athletes, Evaluation and Examination, in addition to other publications related to adaptive sports. Dr. Uihlein, you now have the floor.
Thank you so much for that really kind introduction. Hey, great. All right. So again, my name is Mike Uihlein, and I am lucky enough to be the team doc for the U.S. National Para Ice Hockey or Sled Hockey team. And for people who aren't familiar with what sled hockey is, it's hockey for men and women with lower body disabilities, and a quick video is worth 1,000 words for me. So
on the end of his stick. He has done this so many times in this week and in the last.
So you can see that these guys are playing
to his good buddy Declan Farmer, and Farmer takes it
they're playing in sleds, which are like a prosthetic, basically. They're using two sticks instead of one. It is high-paced contact sport. And it's really it's just fantastic. The sleds are unique. All right, so you can see sleds here. These are a bunch of sleds for athletes on the team that are double amputees, right? And you can see how each one of these sleds, the bucket is actually molded to the individual's lower extremities, right? And when you look at that, you can also see then how they're strapped in. So this is for one of our Marines who was a bilateral below knee amputee after being injured in Afghanistan. You can see the buckles. You can see how this is the way they this is what they're playing in, right? And with that, this is what they're using to propel themselves on the ice. So here are two sticks at the end. You can see those sharp picks, and that's a goalie stick. So that's the side of the goalie stick. The goalie is in plexi. They're in the same type of sled, but instead of blades, they're on plexiglass, and they can slide side to side, actually have a track shoe on the bottom of their glove hand so they can push and move from post to post in the net. And so you can already see, as a sports medicine or a doc covering a sled event, that this equipment can create really unique injury patterns, right? And not only that, because each one of these athletes are bringing with them an underlying diagnosis or disability, it creates really unique situations for care as well. And so with that, one of the things that you can see is stuff like this. We're like, hey, Ben, you're bleeding. You better come on over. So, well, Ben, if you can see, that's blood on his sock. He was actually picking himself, and because he's got no sensation due to spina bifida in his lower extremities there, he didn't even know he was doing it. So we end up with an injury like this that you have to take care of and then protect him down the line. So we added actually we added, in addition to his hockey shin guards that he's wearing, a soccer shin guard that he wore on his side. So these little things that we were going to do, these are the gloves, right? And if you look at that, you can see how when they're skating, they're leaning on their gloves on the ice, and they wear through gloves like that. Like a normal set of gloves will take people, a lifetime to wear through for a stand-up hockey. But you can see that. I mean, literally, this here is all of those finger padding and protections, right? I got a bag of them, because when one of them falls out of a glove and the ref picks it up, he hands it to the guy who's standing down the side of the rink, and that's me, right? So he hands it to me, and I put it in my pocket. I got a bag full of them, and that is how a hockey glove for stand-up hockey just doesn't protect well for sled hockey, right? So what does that lead to? It leads to different injury patterns, right? So we've got a lot of finger injuries, a lot of upper extremity, a lot of nail injuries. And this honestly is our captain, who played the entire third period of the gold medal game of the last World Championships with that injury. He's like, I think I cut my finger. And we basically steri-stripped them together and then corrected and completely put them together at the end of the as soon as the game was over, and washed them, cleaned them, took care of them with this. And so these are some of the things that you would see for sled hockey, right? And again, for adaptive sports, I mean, this is what it's all about, right? Getting people involved, getting young kids involved. And sled hockey at the highest level, these guys are just incredible athletes, but you can play at any level with any age. And I encourage people to really get involved with this, because, having someone who is out playing and having fun that needs to actually use a pusher sled is and see that person just light up when they, catch a pass or score a goal, or just are out on the ice skating, is just absolutely fantastic. And so with this, people would say, well, how did you get involved in this? And for me, it was actually just fortunate luck, because through the local rink, I met their assistant coach at the time, and he's like, hey man, ER, this would be a good background for these guys. And I looked at him, I said, you kidding me? Don't you want someone who knows what's going on? Like someone with, someone with, more training or ortho or this. He's like, no, the ER is a great background. And I went to the first practice and I saw what these guys were doing, and it was like, boom, that's it. I am all in. And that was 12 years ago. And that's actually the reason why I wanted to do the sports fellowship backwards after being out of practice for 13 years instead of right out of residency, because as an ER guy, I was really comfortable with the ER side of things. But now, as Kyle and everyone else will tell you, and Stephanie and Irf, you're traveling with these guys sometimes up to 3 weeks for the Paralympics. And now, as an ER guy, I'm taking care of someone longitudinally, which is something that we're obviously not. That's not our forte, right? It's like, oh, I think that this is your diagnosis. You're going to be seeing, any number of other ortho or non-op sports people, right? So now that was me, and I'm like, okay, I've got to up my game, and that's the reason I went back to fellowship. So the things that are so interesting from a person who came into this without that background and then gained more background is these injury patterns. The fact that sled hockey specifically, right? You are looking at upper extremity injuries, both acute and overuse. You're checking and being checked into the boards, not the glass. So that's like being checked into any wall, right? Like, and these guys are skating the fastest on a dead sprint, 18 miles an hour. All right, that's like a car crash, right? So there's potential for real trauma. So you have to be in and you have to anticipate that and be prepared. Even to the point where you're getting someone off the ice and thinking about that. And then if that person normally is in a wheelchair, where their wheelchair isn't there, or if they're using prosthetics, you're going to have to be able to transport them. So we become very creative in ways to transport people and have to think about that because so some of our guys, if we have to put them on a board to transport them, they're not going to be able to even bring their legs straight because of contractures. So we have to anticipate and know our athletes. Same thing with concussion, and the same thing even with rink stuff. You think about showers, right? And having to get, shower chairs. You go to a rink and their shower chairs are literally, plastic lawn chairs that are like, and that's a safety issue. And we have to think about that as we are with, as we kind of take care of and travel with these amazing athletes. It's really something else. And then the biggest thing that I really want to encourage everyone to think about is being involved. There's local organizations, there are national organizations, and each state has a fantastic well, you look at Movement United, and there's 17 organizations in Colorado alone, and a dozen in Wisconsin, and they all have opportunities to become involved with adaptive sports in one way or the other. So I'm looking forward to any questions. It is such a great sport, and we are, moving into the Paralympic year, and we'll be in Milan in March. And this is my email, and I am happy to take emails from anyone. And I really appreciate and I'm honored to be here with the other presenters. And thank you guys very much for this last 10 minutes.
Uh, Thank you so much, Dr. Uihlein, for that amazing presentation. It was really interesting to hear, some of the specific things to kind of keep in mind when caring for Paralympic athletes in hockey. So now I have the pleasure of introducing our next speaker, Dr. Kyle Nagle. Dr. Kyle Nagle earned his MD degree from the University of Wisconsin-Madison Medical School and his MPH from the University of Washington. He completed his pediatrics residency at Seattle Children's and his primary care sports medicine fellowship at the University of Wisconsin-Madison. He is the head team physician for the U.S. Paralympics Nordic ski team and has been a team physician for the U.S. ski and snowboard and the U.S. Nordic ski team. He has also been an international medical classifier for the International Paralympic Committee in Nordic skiing and biathlon. His professional interests include athlete development, including resiliency and continued lifelong athletic involvement for all ages and abilities. Dr. Nagle, you now have the floor.
Thanks, Maya. It's always hard following Mike, so I'll do my best here. First of all, let me share my screen. So this is when Joan asked me to do this, I was excited. I think it's great to have the people who are interested in this. It's a great way to get involved with high level sport, and it's really an underserved population and community. So it's cool just to share that and to share what my path was, as well as what to look for, what I experience when I'm traveling with the team that I travel with. Our team has some similarities to sled hockey, as in some of our athletes are sitting down, but otherwise, and they're using a similar locomotion pattern, but it's not nearly as trauma based. So we'll cover this other perspective here. So my path, really, I'm gonna go with kind of start from my path and then get into the things. I became obsessed with cross country skiing. I was skiing all my life, but really became obsessed with racing in college. I did not race for my college team, but I was involved with running the races. And then after medical school, really started racing a lot. And then after residency, I really went deep into it. When I matched to fellowship, then I had the opportunity, I found out of my own interest and just through community that there was a pro Nordic ski team based in Madison. And so got in touch with them, and my program director was super supportive and just basically was like, "Hey, I'm going to be doing training here. Do you guys need a team doc?" And my program director said, "Yeah, we'll just write it inside of practice. I'll be your supervisor, not a problem." And so, and the team was like, yeah, we'd love to have a team doc. That'd be awesome. We haven't had one. And so I became involved with that team just as their team doc. And then the director of that program became very interested in Paralympic sport. And I don't know how that happened, but he ended up organizing a World Cup, Paralympic Nordic World Cup race up in northern Wisconsin. And at the same time, basically asked me, because I was working with him with the pro team, hey, Kyle, we're having this Paralympic event up there. There's this thing, and I did not know anything about this at the time, but he said there's these people who are classifiers, which basically say if someone is eligible to compete in Paralympic sport, and if so, what sport class they would compete in. Do you have any interest in doing this? And I said, like any good fellow would do. I was like, sure, absolutely. And so I ended up going up to this training and found out that it's at the time there are only really three. There was one technical and two medical classifiers internationally for cross country skiing and biathlon at the time. So I took the seminar, got certified as a classifier. So then I started traveling to World Cups doing classification and not as part of a team, really as an official for the International Paralympic Committee. And I did that for a couple years and ended up. And so this is what I mean by classification. So you have normal skiers who there's different styles of skiing similar to swimming, where it's like you have backstroke and freestyle and breaststroke. And for us in skiing and cross country skiing, you basically have skate skiing or classic skiing. And so there's people who are standing athletes who have different impairments. Some are visually impaired, so that's what the picture of the two Canadian skiers right there, and the guy in the back is blind and is being guided by his guide in the front. You have some people who have can't use poles because they don't have arms, or they are impaired in one arm, and so they only use one arm. There's some people who have lower extremity impairments, so they'll ski with a prosthetic, like this Argentinian skier here. And then some people can't stand, and so then they go into the sit ski classes. And typically at any Nordic ski event, there's three kind of races that are going on: the VI or blind, visually impaired skiers, the sit skiers, and the standy skiers. And we also do biathlon too, so I wanted just to throw that in there. And the sit skiers sit in various different kinds of buckets, very similar to the sled hockey buckets. A lot of them, especially at the higher level, are custom formed, completely out of carbon, or they'll have a thermomoldable plastic bucket that's attached to an aluminum frame. And there's various different styles of this and different things, and it's very personalized as far as what that setup is and how they're attached to the ski. But they're typically attached to two skis. The skis stay straight forward, and they turn by basically either carving a little bit by getting the skis up on edge, or by just pulling and pushing themselves around a corner. So it's interesting that as far as it goes. So then after a couple years of just being classifier, I ended up going to Sochi for the Paralympic Games in Sochi as a classifier. And there I started to meet, and through this process, I started to meet more and more of the U.S. ski team. For the able-bodied people, I started to meet the staff and coaches and athletes for the U.S. Paralympic cross-country ski team. And so then shortly before Korea, a couple years before Korea, they asked me to be their team doc. So I became the team doc for the U.S. Paralympic cross-country ski team. I was also doing some work as a team doc for the Olympic team as well. But this really ended up becoming much my focus. And it was really interesting for me. And I think it was helpful is for those of you who are interested in working with a team. I think it's really helpful if you have the opportunity to do it, to work in a sport that you know well. It ends up helping out because you can help them out in more than one way. So a lot of these big competitions, they have limited credentials. And so if you can help them out in other ways around, or even if you don't have any specific skills, just being part of the team and just helping schlep gear, or getting athletes from one place to another, that's a huge. So a lot of it is not necessarily being a lot of medical stuff. It's just being present and able-bodied and being a good team person, right? And with skiing, I had enough skills that I could actually help out with a lot of ski service stuff. So I was helping to test skis, I was helping to wax skis and things like that. That for me, I find really fun. But I was also at the venue and could do medical stuff as well. So it's really kind of wearing multiple hats at the same time. And then we went to China more recently. Very different environment, masking. It was just a different environment. The team still did really well. I still did some ski service stuff. Yeah, that was kind of the path. And then still planning at this point on going to Milan Cortino this coming winter. So it's been an interesting path, and a lot of it, I think, for those of you who are even interested in this, a lot of it had to do with just me following my interests, and opportunities just came up as I expressed interest and showed aptitude and enthusiasm for what I was doing, and just kind of being a team player. But it was, I think there is a certain part where, hey, if you have an interest in something, go for it. And then I also just want to talk some about what medical problems I see, because I think people often get worried about covering Paralympic sport because they're not as comfortable with it because they don't know as much about it. So I do want to cover some of what we see more on an endurance sport side of things. And Mike can, and Irf, you guys can, Stephanie, you guys can pipe in if you've seen this as well. But the things we see a lot of times for Nordic skiing, actually a big part is illness. And we see this, and there's data out there. This is my one like data slide of the whole thing. But this was just saying, hey, medical illness is higher in Paralympic athletes than in Olympic athletes. Why, we don't even know. In fact, there's a little bit more even specifically in women Paralympic athletes. Again, why? Causation, no idea. But we definitely see this. And for cross-country skiers, it's being an endurance, they're really functioning right at the edge of their capacity. And with that level of training, oftentimes they do get some immune suppression. And so they're really susceptible to these things. And infection control is a huge deal. But we see a lot of respiratory stuff, digestive stuff, dermatologic stuff. I'll get into that more. So specifically in Beijing, we had various different challenges that came up. One, air quality, especially in the second half of the games, really became a huge issue. And a lot of our athletes do have asthma. It's big in cross-country skiing in general. And the air quality, and this was middle of the day. This was like noon. This was between races at a place. We weren't even near a big city. We're really close to the border of Mongolia. But it became a big issue. A lot of people were having asthma exacerbations, not feeling great because of that. The other thing we had challenges with food, what we think was foodborne illness. We had a lot of GI issues that came up, and it wasn't in this setting when the Olympic Village, the food options were limited. And so it is something, GI illness definitely is an issue that you have to pay attention to when you travel. Just traveling in general, traveling internationally, different food, different dietary habits. Oftentimes at the villages, they have a lot of different options, but there was pretty limited in this specific games. Granted, we still find time to go out, have fun. This was still during COVID time, so we had the plexiglass when on our team night out, we went out to a local restaurant and we drew pictures on the little plexiglass between us. It was still fun. We turned it into a plus that way. Um, One big thing that we see is dermatologic issues, and they can become emergencies. This is just an evolution of one skin issue that we ended up having to evacuate an athlete from an international location because this was a skin issue that really flared up, got worse. Tried doing debridement and irrigation, tried various oral antibiotics to continue to get worse, and eventually we're like, we gotta set it out. We were worried about osteomyelitis, could turn into sepsis, necrotizing fasciitis. And a lot of times the treatment of this though is really to offload it and then treat it like a skin infection. But they're just at such increased risk because they're either sitting all the time because they're spinal cord injury or they're wearing prosthetics, which may or may not fit really well. So it's just something to keep in mind, and it can become a really big issue because they may or may not be able to ambulate or move as well as far as getting around just in general, let alone performing well. So that's just something to keep in mind. Granted, besides illness and skin infections, we do see some trauma. This was a well-publicized case of a woman, and it's out. All the information is out there. Was kind of one of the bigger stars, still is, of our team. And about 2 weeks before the game, she slipped on the ice and dislocated her elbow. We were able to get her back in the middle of the game. She redislocated, and through a team effort of everything, we were able to get her in here, and she won gold medal in this race and some others after that. But we definitely see trauma as well. It's just not nearly as common as Mike sees or Irf in rugby, but we see it. They are all the sit skiers are strapped into their buckets. They do go downhill very fast. I've seen other things as far as wrist fractures, shoulder injuries. For us, overuse injuries are big. Really big ones are any upper extremity stuff. Again, for a lot of sit skiers, that's the only thing they're using. Lower back in cross-country skiing is very, very common to have lower back pain. And a lot of times you're just managing it. The actual management is very similar to any other athlete that you treat. it's sometimes it's the modification of activity that becomes harder. So if someone uses a wheelchair to get around and they're having shoulder pain, you might need to be like, all right, a little more thoughtful about how you get them around, or you have teammates push it, even though that might impede their independence. And it really does change your perspective there as far as how you're treating this and whatever. So sometimes there are some things that are different, but a lot of that basic treatment, if you take it down and just simplify it and kind of take that deep breath, is very similar to everybody else. So a little bit of demystifying, pulling the curtain back to do it. Hey, it's not that much different. Are there a few things, autonomic dysreflexia? There's a few things extra that you need to know, but most of it, it's all learnable. And it's really, a lot of it is just the same, and just being open to being like, hey, treating it, everybody's impairment is so different that just treating everybody as an individual is super huge. So I encourage you guys all, if you get the opportunity and have any interest at all, please pursue working with or exploring adaptive sport. It really is an underserved population. People really don't know very much about it. And these athletes, a lot of times, even as they get higher levels, they're traveling all the time. So they really don't have a medical home. So a lot of times I'm doing phone consultations and case management, just trying to figure out where to get them to the care that they need. We're very decentralized as a team. So that's part of the issue too. So anyway, that's all I really had prepared. But so I'll turn it over back to you guys and be open to questions later. Thank you.
Thank you, Dr. Nagle. That was an excellent presentation. It was so interesting to hear. Thank you for sharing your experiences. And now I'd like to introduce our next speaker, Dr. Stephanie Tao. Dr. Stephanie Tao is a physiatrist who is dual fellowship trained and board certified in pediatric rehabilitation medicine and sports medicine. She's also board certified in physical medicine and rehabilitation, or PM&R, and brain injury medicine. She is an assistant professor in the Department of PM&R at the University of Colorado in departments of pediatric rehabilitation medicine and the Orthopedics Institute Sports Medicine Center at Children's Hospital, Colorado. She is currently the head team physician and medical director for Team USA Paralympics Swimming's national team, as well as national medical classifier for U.S. Paralympic Swimming. She also serves as the medical director of the adaptive sports program at Children's Hospital, Colorado. Dr. Tao has a passion for working with athletes of all abilities, including adaptive and parasports athletes, and has experience in many other leadership and volunteer roles related to adaptive and parasports. She has presented and co-chaired multiple national and international adaptive and parasports medicine educational sessions and courses. She's an advocate for equitable access to participation in sports, recreation, and physical activity and sports medicine resources for all athletes. Dr. Tao, take it away.
All right. Well, thanks everyone for being here tonight. Thanks, Maya, for introducing us. And I have the tough job of following Mike and Kyle. Fortunately, not Irf. But I'm looking forward to your talk too, Irf. So I'm going to share my screen right now. Mike, let me know. Can you see my screen?
Yes, looks great.
Perfect. Well, I am here tonight to talk about my role in Paralympic swimming and our sport. So growing up, I was a swimmer. I did multiple sports, but my siblings and I primarily focused on swimming. And then along my medical career in medical school, I realized I had a really big passion for adaptive and para sports, and had realized at that point that I might want to create a career around para sports medicine at that point, but was still trying to explore because that doesn't really exist as like a standalone like ACGME subspecialty that you go into. And so had some mentorship along the way, and along that time, when I was applying for my pediatric rehab medicine fellowship, I met my fellowship director, Dr. Pam Wilson, who is a pediatric rehab physician at Children's Hospital, Colorado, mostly retired. She's in phased retirement right now, but she is a Paralympian in wheelchair curling and has also done a lot in a lot of other Paralympic sports. And when I interviewed with her, so I hadn't even matched yet, she realized I had a passion for parasports, and she loved my interest in there, and sent me an email, I think the day after rank lists were due. And I always joke that she was really bad at emails. And I was like, were you trying to recruit me and you forgot that the rank list was due the day before? But she let me know that Paralympic swimming had an opportunity for a classification course. And so that's similar to Kyle. That was my entry point into the Paralympics world was I served as a Paralympic classifier first. And so for classification, like Kyle was talking about in the Paralympic movement, each of the Paralympic sports that are recognized by the International Paralympic Committee have this classification process to determine how does that athlete's impairment impact them in the functions required for their sport. And that determines their eligibility in the sport, as well as what class they compete in. And so in Paralympic swimming, I always joke that we are one of the most inclusive sports in the Paralympic movement. We include all the impairments that are recognized by the International Paralympic Committee. And so that's physical, visual, and intellectual impairment. And so I specifically classify for physical impairments. And then moving ahead, when I was in my pediatric sports medicine fellowship, after I've been working with Paralympic swimming as a medical classifier already for a few years, I recognized that they didn't have much medical infrastructure in place. And I started asking, who's your team physician? Who does all of your guys' medical planning, your emergency action plans, all of those things. And they had no one. And so fast forward, they said they were interested in having me as a team physician, but what really, really expedited it was at an event at which I was classifying and the only medical professional there besides, first aid, lifeguards. We had a medical emergency on the pool deck where one of the athletes I had just classified, she was an adult athlete with dystonia and Parkinsonism syndrome. And I had just classified her, so I knew all of her medical history. She traveled to this event out of state all alone, no family with her, and she suddenly could not breathe because she had a dystonic crisis with a lot of dystonia in her neck. And fortunately, she was out of the pool, so it didn't happen in the pool, but I was able to escort her to the local community emergency department. And I thought that was critical because I knew I didn't want to just ship her in the ambulance alone and no one knows her medical history. And she goes to the community hospital and, you see scary things at our hospital systems once you've done your intern year and residency and fellowship where people are like, oh, no, she's at baseline. She's fine. Discharge her, right? Like I wanted to make sure they knew that she was not at baseline and I really advocated for her. And so that's when a couple months later, I got a contract with US Paralympic Swimming as a sports medicine fellow. So similar to Kyle, to be their team physician. And then shortly after became their head team physician as Dr. John Finoff, the CMO of the US Olympic and Paralympic Committee, started building more infrastructure for all of the sports under USOPC and recognizing that every sport needed a head team physician and medical director and all of those things. So classification, every sport is different in the Paralympic movement. And so you can see here highlighted in yellow, that's swimming. You can see we have a lot of different impairments recognized under the IPC, but not every sport takes all of those impairments. And so it's up to the sport on what they accept. And so we take all of them. And then also visual impairment and intellectual impairment. And you'll see here, there's only 3 sports that include athletes with intellectual impairment, and we are one of them. And so these are all of the eligible physical impairments and the variability of things that we see. And these can be from a lot of different medical conditions. This is a paper from Dr. Wayne Derman looking at, they outlined the most common impairments that we will see in the Paralympic movement. But again, this is also variable depending on the sport that you're looking at. But in general, these are pretty true when you look at all of the sports overall. So these are the more common conditions you'll see, but you'll see a lot of variability, which then impacts what you see medically when you're taking care of these athletes. And so in paraswimming, we also are complex with our classification, where we have some of the most classes. And so in general, with the classification system, the lower the number, the more impairment that you'll see. And so versus a higher number means that they have they have the most function based on their impairment. And so in swimming, S1 through 10, those refer to freestyle, backstroke, and butterfly. Those will be the physical impairments versus the 11s through 13s will be visual impairments. And then the 14s there's just one class for them. They have intellectual impairment. breaststroke is the SB class, and then SM is a calculation based on these two to determine the individual medley class. And so again, that's true. Like the 11s will have more visual impairment than the 13s, and then the 14s are just one class. So at the elite level, we do tend to see some of the impairments and medical conditions get classed out because some, Down syndrome, if you have Down syndrome, you're going to have way more intellectual impairment than someone who has high functioning autism who can be eligible for intellectual impairment. So we tend not to see as much Down syndrome at the elite level, but when you're covering paraswimming events at more recreational or grassroots levels, you're going to see a lot more variability and a lot of more complexity with medical conditions. Likewise, the classification system doesn't do really well with integrating different impairments. So if you have a physical and an intellectual impairment or all three, you're going to be at a disadvantage when you're competing at the elite level. And so they tend to also get weeded out by competition. So we don't see as much of that complexity at the elite level, although it's been getting we've been seeing it a little bit more. But definitely at the grassroots and recreational level, we may see people with all three impairments or multiple different physical impairments. So it can be quite complex. And then this is just a little overview that in classification, particularly for paraswimming, it's based on function. So within a class, so this is an example of the S6 class, people can look different, but the thought is that all of these people with different impairments, their impairments impact them similarly in the function of swimming. And so likewise, you might have the same medical condition as someone else, but they may be in a different class. So like if you have cerebral palsy, but your cerebral palsy only impacts 2 of your limbs versus 4 of your limbs, you may have different levels of impairment. And so you may be classed into a different class depending on what you look like. So that's a consideration. I just wanted to show you this video.
Yeah, Duo did get away again. Well, what was impressive this morning was the way that he accelerated away from the field. You can see that sort of bullet that he uses as he goes through 25. He does have the lead. Oliveira going well for Brazil, but also going well is Yuan in 5 and Wang in 6. But once again, it is Duo with that motor boat leg kick leading them through.
Well, amazing swim here from Guoying Cheng, and he's inside the world record again, 29.78.
So 29.78, pretty dang good for a 50-meter swim. I think that, he probably can swim better than most of us in the medical field, swim faster. And so that you could see in that video that everyone looked a little different with how they swam, right? And that some of it's technique, but some of it's also the variability and impairment. Also, our athletes with bilateral shoulder disarticulations, which that lead athlete had, they oftentimes they have to hit the wall somehow. So they hit their heads, right? And so it's pretty understudied on what's the impact on concussion or cervical spine injury, right? So there's like so much room for research in the para sports world. In swimming, just like in Olympic swimming or with USA swimming, we most commonly see the shoulder as the most commonly injured area. And that's usually a chronic injury, or it could be an acute on chronic. We also see a lot of illnesses like Mike and Kyle were talking about. We see respiratory illness is the most common, but we see GI illness, urinary tract infections, especially, when you consider what my athletes' medical histories include. So if they have spinal cord injury, cerebral palsy, a neuromuscular disease like different types of myopathy, they're going to have pulmonary issues at baseline, right? So they're at higher risk for respiratory illness. They may be at risk for UTIs due to neurogenic bladder. Their UTIs can be scary because they can get septic very quick. They can turn into pyelonephritis. So those are all things that we need to be aware of. And so their history is really, really important to look at. And then also, depending on what their impairment looks like, that might impact them biomechanically. With my athletes with visual impairment, I see a lot of concussions. I've had athletes with 10 plus concussions, and there's a lot of recognizing the importance of seeing a physician when you've had a concussion, or the importance of not, continuing to participate in sports. And so, what swimming is considered a non-contact, non-collision sport, sometimes in paraswimming, it ends up being a collision or a contact sport. And then with neuromuscular diseases, we see muscle fatigue, we see worsening of their spasticity and dystonia that leads to a lot of pain, and increased risks of injuries, as well as higher risks of fractures if they have low bone mineral density. And then the challenge with working with athletes with intellectual disability is understanding how much do they understand? How do you need to work with them and communicate with them so that they trust you? And also being able to discern, are these symptoms we really need to look into, or are these that, when they're like, oh, never mind, it's fine, is it really fine? So, and then we just talked about that one. So this is just data from the Pan Am Games in Santiago in 2023, and just shows right here in the gray, you can see that para swimming, we are one of the top sports that have a lot of injuries and illnesses. And then top overall problems in our sport, muscle soreness is most common, followed by muscle tightness and back tightness. So it's also important to remember that athletes' your teammates' medical conditions might impact your injury risk as well. I have seen, unfortunately, athletes with visual impairment accidentally dive into another lane where an athlete with osteogenesis imperfecta, also known as brittle bone disease, also swimming. And so that collision could cause a big, scary fracture in that athlete with OI, right? So watching for that. And then we also see a lot of medical conditions outside. So just, I think it's when people first get involved with para, they get really excited, but they tend to hone in on the impairments. But don't forget that we see a lot of other medical conditions too that are not necessarily related to their impairments. And they may have a lot of other medical issues that are not eligible by themselves to class into their Paralympic sport, but they still have these things going on. And so we see a wide variety of medical conditions. We're one of the largest national governing bodies here in the US. And so we therefore see a lot of different medical issues. And then don't forget mental health as well, psychosocial issues. So it's important to think about all of these things when you're doing medical coverage, when you're planning for an event as a medical director or as a team physician, and you're packing your supplies or building your team. And then knowing the classification system is really helpful. So I think Kyle and Mike have talked about, like, if you're familiar with the sport, that's going to get you, an edge over someone else who does not know the sport. But then also knowing the classification system and how it works is really important as well. And then a lot of times resources are lacking in the para sports world. And so oftentimes we have to get creative with how we build our infrastructure or what resources we provide to our athletes. So those are my take-home points. And that's my email and Twitter if anyone wanted to reach out.
Thank you so much for that fantastic presentation, Dr. Tao. Okay, and now it's my pleasure to introduce our last speaker for tonight, Dr. Irfan M. Asif. Dr. Asif is the Associate Dean for Primary Care and Rural Health and Hersink Endowed Professor of Sports and Exercise Medicine and Chair of the Department of Family Medicine and Community at the University of Alabama at Birmingham, or UAB. He is certified in family medicine and sports medicine. Dr. Asif hopes to bring infectious enthusiasm for everything family medicine and sports medicine, including the ability to provide excellence in patient care, to be outstanding educators, and to always strive for quality improvement, and to provide service in a number of venues. In his role as Associate Dean for Primary Care and Rural Health, Dr. Asif is working with UAB Hersink School of Medicine leadership, UAB regional campuses, and other key partners in Alabama and beyond to improve the primary care pipeline and address disparities in health outcomes, including in rural communities and in urban underserved areas. Dr. Asif is currently serving AMSSM as the second vice president and will become the AMSSM president at the 2027 annual meeting in Louisville, Kentucky. Dr. Asif, the floor is all yours.
Awesome. Thank you so much for the kind introduction. And it's so nice to be here with all of you and to follow these esteemed colleagues that we have on today. Just letting you know that folks like Dr. Uihlein, Dr. Nagle, Dr. Tao, they are giants in this field. And again, I'm honored to be on the stage with them today. I am the team physician for USA Wheelchair Rugby, but today Joan asked me to talk a little bit about cardiovascular conditions in Paralympic athletes. I'm happy to talk about my experience with USA Wheelchair Rugby, but But again, we have some amazing experts, and I think you've seen some sports-specific things. So I wanted to get a little bit into some pathology just to help you understand some of the differences. So sudden cardiac arrest is the leading cause of death on the playing field. I think for us, many of us would remember Damar Hamlin, for example, and many other elite athletes that may have succumbed to cardiac arrest, but we don't often hear about Paralympic athletes. That could be for a number of reasons. We don't actually understand the epidemiology of cardiac arrest in Paralympic athletes, but it also could be underreported. But I imagine as we start to see more athletes in the Paralympic space, this will be more common, and I think we need to be prepared. So what are some of the common conditions? I'm going to go over just a couple just to help you understand, if you take care of Paralympic athletes, what you might be on the lookout for. So Stephanie did a great job talking about some of the different types of impairments. Spinal cord injury does present some significant cardiac risk. And when you think about spinal cord injury, any athlete with spinal cord injury would be at risk for autonomic dysreflexia and orthostatic hypotension. There's actually some very interesting data on spinal cord injury and cardiac remodeling. You actually have a smaller left ventricular cavity and mass. So when you look at spinal cord injuries, they have a smaller left ventricular cavity and also a smaller septal thickness. Endurance athletes tend to have a little bit of a bigger cavity, so you can see differences between endurance athletes and those that are not endurance athletes. Interestingly, then, as you have a different size in your cavity, you can have an increase in risk for arrhythmias and structural heart disease. So those are some things to think about for spinal cord injuries. For those with limb deficiencies or amputation, that actually causes pressure overload, and people can have hemodynamic strain that causes people to have more pressure within the cardiac cavities. Interestingly, then, the people with unilateral lower limb amputations can have significantly high blood pressures, and that's something that we need to watch out for in these athletes. So again, hypertension and the pressure overload is something to watch. And then finally, as I just sort of go over some of the unique things that you might see, I wanted to talk a little bit about neuromuscular disorders. So neuromuscular disorders, I have some examples here, but you can see that many of these disorders can cause different muscle tissue type, particularly in the myocardium. That can lead to things like dilated cardiomyopathy and fibrosis or scar. That then can lead to lethal arrhythmia potential and heart failure. And so when you're trying to put this into perspective, the underlying heart conditions in your traditional athlete might occur in 3 out of 1,000 people. But for the Paralympic athletes, studies from Italy and Norway and other places actually show that it's 2 out of 100. So there are definitely underlying cardiac conditions that we need to be on the lookout for. And some of the screening that we may do that is a result of this high-risk population should probably be a little bit more than we traditionally do. But oftentimes, as we've heard from our other speakers, these are under-resourced athletes. So I think we need to think about how we might be able to get better resources for these individuals. So what do you do with a collapsed and unresponsive athlete? So some of these folks on the call today were at a talk that I gave just a couple months ago. And as I was preparing for that talk, I realized that there was no resource available for demonstrating how to do CPR in athletes with disabilities. So we went ahead and made a resource, and I wanted to share that with you today. It's a 4-minute video, so I'm going to go ahead and share that.
And team physician for USA Wheelchair Rugby.
Thank you.
Sudden cardiac arrest is a leading cause of death on the playing field, accounting for 75% of fatalities. Remember, every second counts in cardiac arrest. For every minute that we don't provide defibrillation, survival decreases by 10%. This video will walk you through a step-by-step guide on how to administer CPR and provide defibrillation in people with disabilities, covering important adaptations. The following is a step-by-step guide to administering CPR to a person in a wheelchair. Assess the scene and the person. Ensure that the scene is safe for you to enter. Check for responsiveness by tapping the person and asking them if they are okay.
Okay, are you okay?
Is he responding?
No response.
All right, you
Call 911. You get an AED.
If there is no response, summon emergency medical personnel or call 911. Get an AED if available. Check for breathing and a pulse for no more than 10 seconds, and for amputees, consider a carotid pulse if needed. If no pulse is found, begin CPR. Position the person for CPR. If possible, transfer the person to the floor by locking their wheelchair brakes if they have any, tilting their wheelchair back towards yourself until the back of the wheelchair is flat to the ground. Unfasten the seat belt if one is used. Using safe lifting techniques or with assistance, hook your arms under their armpits and pull them out and away from their chair. Place them flat on the ground and begin compressions. If an AED is available, place one pad on the bare upper right side of the chest and one on the lower left side of the chest. Remember these adapted sport considerations. If you cannot transfer the person to the floor, ensure that their back is upright and full access to the chest to begin chest compressions. If they are in a large power chair, use the tilting option on the chair to lay the seat back. This is not ideal, but the compressions can be done while seated, so there is no delay in CPR. An AED can be administered to a person while seated in a wheelchair if transferring them to a flat surface is unadvised. For high-level spinal cord injury, expect autonomic dysreflexia. Do not pause compressions. Treat after return of spontaneous circulation. For fragile bones or severe scoliosis, compress to the same depth. The effectiveness of compressions outweighs fracture risk. AED pad placement. Standard placement on the right upper chest and the left lower ribs still works 90% of the time. Consider anterior-posterior pads when chest access is blocked by a seated shell, heavy straps, kyphosis, or a colostomy bag. There is an implanted device, such as an ICD, that sits where a pad may be. Then you can shift at least 1 inch away. There is excess chest perspiration. Make sure you wipe sweat away quickly so that the pads adhere and energy does not arc. If you opt to use rescue breaths, remember these potential variations. People with tracheostomies or laryngotomies, those with C-spine fusions or halos, or those with high-level spinal cord injuries. Ensure that your team is prepared. Add trauma shears, towels, spare AED pads, and a trach adapter to every sideline AED. Consider drilling 2-person chair-to-floor transfers in tight spaces, thinking about locker rooms or bus aisles. Include athletes with disabilities in every practice scenario. They can operate the AED or direct care. Remember, lock, tilt, pump, and pad. Lock wheelchair brakes or hit the power chair emergency switch. If there are 2 rescuers, tilt the chair back toward you until the seat back is on the floor. You can use hands-only CPR, aiming for about 100 compressions per minute. Use the standard locations of the right upper chest or the left lower ribs, unless they are blocked. Follow the AED prompts and minimize pauses in chest compressions. We hope this video serves as an important resource for how to provide care in athletes with disabilities during cardiac arrest.
Awesome, and really appreciate the Lakeshore Foundation allowing us for the chance to work with them to create that video. That was basically the end. I wanted to make sure that people learned how to do CPR in athletes with disabilities. So again, I appreciate the opportunity to create that video. You're the second audience to see it. So if anybody has any feedback on things to improve, please let us know. Maya, I'll go ahead and turn it back to you.
Thank you so much, Dr. Asif, for that outstanding presentation and for sharing that video on CPR with us as well. That was a really great resource, and we really appreciate you sharing that with us. So now we are going to begin our Q&A segment with our speakers, but I wanted to once again thank everyone on our speaker panel for their amazing and informative presentations. So if anyone has any questions, feel free to put them into the chat. But looks like we do have one question for Dr. Nagle. What are effective techniques to offload the stump to treat skin breakdown? Donuts, silicone gel, etc.
Yeah, it can totally, yes, the answer is yes. Any way you can get weight off that. If it's a prosthetic getting as much time out of the prosthetic can be hugely beneficial. If someone is usually ambulating on their prosthetic, then sometimes they need to use a wheelchair. Oftentimes, we'll, at our level, we're still trying to get them to have ways to train and or compete. So sometimes it's about limiting the time in whatever bucket it is, or whatever's putting pressure on there. Long term is really, you have to work again with a multidisciplinary team, working with your prosthetists, working with we have the people who make the buckets can be anything from auto or aerospace engineers, sometimes, and aren't necessarily prosthetists, but are very good with the material. And so working with them to find ways to avoid having that rubbing or that fit issue down the road is a huge thing. But in the short term, it's really, if someone is seated and they can use donuts, make sure that their seating pads, if they are wheelchair athletes, sometimes their seating pads get worn down and they need a replacement. But if they are someone with a spinal cord injury, sometimes it means, hey, stay off your butt literally as much as you can. So if you're not actively training, be lying on your bed, moving from side to side so you don't get other sores as well. But sometimes it gets to that point where you're just like, hey, we just got to get the pressure off of it. So that's the primary thing. However it works is getting the pressure off of it.
Thank you so much, Dr. Nagle. And then there was another question for Dr. Tao about what preparations are made for water rescue. And it looks like said that it's usually done by lifeguards. Did you have anything else to add for that?
Now, for other water sports, that might not be true, but for Paralympic swimming, our lifeguards are like in competition and practice. At any point, there's always a lifeguard on duty, and so they are trained to extract the athlete or the person out of the water, and then we take over medical from there.
That's a similar case for alpine and snowboard as well. You have ski patrol there, and they're actually the experts as far as extricating and stabilizing on the snow. We don't have as much issues in Nordic skiing. We'll have ski patrol typically there who have like a sled to reach the far. The biggest issue for us is that on our trails, sometimes people are pretty far from the medical center. And so in that situation, we try to make sure, we're all on radios. But it's oftentimes the whatever local organizing committee is at the trails there, they'll have some sort of first aid thing, and we'll often have oh gosh, it depends on what region you're in, what you call it, snowmobile, sled, snow machine, something along those lines that can get you out to the athletes very quickly.
One note about water extraction, it gets a little, you don't always know what the lifeguard's training is with working with different people with different impairments. And so like, I will say the trickiest thing is like someone who has a bilateral shoulder dysarticulation. I've seen coaches pull them out by their head, which seems a little barbaric. So oftentimes, if there is an athlete where you're not sure how to get them out, usually the coach is nearby and they will know how to help get that athlete out. But, like we've seen in like artistic swimming, even right at the Olympic Games, sometimes we're the first one to see it before the lifeguard, but usually we'll trigger the lifeguard to get them, but we may provide them some guidance, or the coaches may be helpful too.
Great, thank you so much. And then we also had a question regarding how cardiopulmonary exercise tests can be done for adaptive sports athletes. And it looks like Dr. Asif answered the question in the chat about using different forms like a bike or arm bike. I don't know if you had anything else to add, Dr. Asif.
Yeah, I think the only thing I wanted to add was, the research on Paralympic athletes. There are only a handful of studies. I mean, I think Dr. Uihlein has all the studies, and he shared them with me that have been done. He's got a library of them. But when I looked at the cardiac literature, there were probably less than a half a dozen. So all that to say, if people are interested in this space, please get involved. And there are a number of ways to get involved. Some of it is just volunteering, as we heard Dr. Tao mentioned, and you can do that even when you're a trainee. Some of it could be in research. And I think these athletes really do appreciate the opportunity to help make things better for those around them, knowing that the research could, again, make sports safer. We do have a study called Parawise that we're doing focused on nutrition, mental health, and exercise recovery. Those are some things that when I interviewed athletes, Paralympic athletes, I asked them, what can we do to help? That was one thing, but there's so many things that could be done for them.
And definitely within the cardiopulmonary testing phase, things can get really physiologically changed. If you think about if someone has an amputation, then trying to use any normative data will be way out there because like VO2 max per kilo, like again, that can go out. And then also if someone has a spinal cord injured person, the way that their blood is distributed or not, they're using all their upper body, but they have all this extra mass there, but it's not super metabolically active, but it's a little metabolically active, plus how much lung capacity they have based on the position. It gets really complicated. And so we're trying to do research on this area is really hard too, because we have limited numbers of Paralympic athletes and they're often spread out. So at least within Nordic skiing, when we were starting to think about this, mostly actually from a classification standpoint, they're trying to get more information on how to do this in a better way. Um, it's hard because the only time you get those numbers are oftentimes at big competitions where people don't necessarily want to spend time when in a research study. They're focused on their performance, so it's not necessarily conducive to that. But really start thinking if you're interested in this field, having a network and recognizing, in the US, we have a very decentralized both athletic and sport program, as well as a decentralized medical field. You're really finding partnerships and building that capacity. I think it would be huge. It'd be awesome to have that. And I think, Irf, what you're doing down there is fantastic. And I think the more we can start doing this and even just getting Paralympics into the USOPC and now USOPC, I can help with that. But really start the challenges to doing some of this research are infrastructurally are difficult. Doesn't mean it shouldn't be done. No, it just means that I think we have to be a little more thoughtful about how we do it and potentially engage in terms of, hey, this may not be a single institution. Maybe we need to do something bigger picture or use the VA that has a shared medical network or shared medical system where we can start to chip away at this. Because like Irf just said, I mean, it is a black box, a black hole that we really just don't have that much information on.
I did have one question that anyone can answer, but I was just wondering for medical students and trainees that are interested in working with adaptive athletes in the future, what kind of early experiences or skills do you think would be most valuable to build before fellowship or practice? And do you have any advice for institutions that want to expand opportunities in adaptive sports medicine?
So I'll say, as a trainee, I think it's really important to make sure you understand all of your evaluation skills, get that foundation set. If you're able to do any rotations, like if you are not in the field of physical medicine and rehab or not in a field where you see all of these medical conditions typically, I would try to do a rotation where you're getting more exposure to the more common conditions we see in the Paralympic movement. So including like that slide I had with cerebral palsy, spinal cord injury, amputees, neuromuscular diseases, so that you can learn about, oh, okay, like this is how we detect a UTI in an athlete with spinal cord injury, because it's not the same as, if you have positive bacteria on your urinalysis, it may not mean they have a UTI, they may be colonized. And so just understanding some of these extra technical things. But, the first thing is getting your basics down for sports medicine training, making sure you understand, getting sideline coverage or other event coverage in general. But then if you can also find local adaptive sports organizations near you, volunteering. And oftentimes as a trainee, you're not going to be volunteering as a medical professional. You're going to be the person helping with like first aid or with, helping transfer athletes up and down, different areas in their wheelchair. That's all still helpful because you get to become familiarized with that sport and the equipment and the language. If anything, it gets you even more excited. My other thing, before I let the others speak, I know there was a question about classification. I dropped a link. Yes, there is a typo, but that's unfortunately the way that whoever created that website, there's a typo there. It's not my typo. So that link should take you. Caveat, that is under USOPC. So I'm not gonna have time to go into it in too much detail tonight, but there's a lot of politics with how the organizations run. For the most part, the majority of the Paralympic organizations are independent. So this link is only for the sports that are run by the USOPC, which are getting smaller and smaller each year because they've been trying to push, like for example, US Paralympic Swimming is still under USOPC because USA Swimming is not, people get this confused all the time. USA Swimming is not the same organization as US Paralympic Swimming, but US Para Track and Field just moved under USA Track and Field. And so if it's not a sport under USOPC, you would have to find that website for that organization. So example, the National Wheelchair Basketball Association, they run their own classification training process. So you would go to the NWBA website to figure out how to become a classifier.
I think some of it too is just get as much exposure as you can, whether medically or even just working with them, working with adaptive athletes. There's a certain part which is just comfort level and not just being like totally doe-eyed. And there's certain things that I found as I started working with them, there's just little things that can help make, I mean, if someone's in a wheelchair, just get down on a knee next to them so you're speaking eye to eye, things like that that can really just help establish rapport. And that doesn't necessarily need any medical expertise, but if you haven't worked with athletes in wheelchairs before or in sleds or whatever, you may not think about it, but if you're around those athletes, you can suddenly see how other staff and how other experienced people are working with them. And it just demystifies it a little bit and just makes you more comfortable. So then you can focus on the medical side and not just, hey, how am I interact? I don't want to offend anybody, which is a real thing. And so just getting more comfortable with that and being able to interact in a reasonable, they're all people. They'll if you ask them questions, they'll answer it. It's just, I think there's a certain part which is just comfort level and just being able to relax with them. Then you can focus on the medical side. Anyway, Mike, go ahead. I see you unmuted and you haven't said anything. Go for it, man. I'm gonna shush up.
No, I was just gonna say, and this to support what's already been said, you just ask the athletes and say, hey, how can I best help you get into, a transfer? Or how, teach me about your equipment. Teach me about, how, you get into, like, how are you secured into your wheelchair or your race chair or for sled or for our local team, we have all different abilities. And so you are actually helping people get in and off the ice and get into, and learning about the equipment and working with the equipment. And I tell you, the Move United is a great national organization. They're a magazine. They just go through state by state, all of the, local state organizations, that you could reach out to if you're interested in. And there are a ton of them. I mean, there really are, and really encourage people to do that and just get involved because it's awesome. It really is. It's just fantastic.
I think the only thing that I'll add is, when you go to residency or when you go to fellowship, ask those programs what they do with, what involvement they have or what teaching they have for adaptive or athletes with disabilities. There are a lot of fellowship programs that maybe they just do a lecture each year. And as you can see in the short time that we've had today, that this is more than a lecture's worth. So if programs don't have it and you feel compelled to go to that program, maybe you could be the kickstart that helps them do more.
That's a great idea. That's awesome. Absolutely.
Thank you so much all for sharing. If there are no other questions in the chat, I think we can close up our Q&A if anyone else has anything else to ask. But before we conclude tonight's webinar, I want to express our gratitude to tonight's speakers. It's truly been an honor to have Dr. Michael Uihlein, Dr. Kyle Nagle, Dr. Stephanie Tao, and Dr. Irfan Asif featured on our speaker panel. This webinar was really informative and very inspiring for everyone who was able to attend. And your presentations were excellent, very impactful to learn about adaptive sports and serving as a Paralympic team physician. The 2026 Winter Paralympics will be taking place in Milano Cortina, Italy from March 6th through March 15th. And after tonight's presentations, it'll definitely have special meaning to watch the athletes compete. And I also want to thank everyone on here for attending tonight's webinar. In December, the MSIG officers are hosting 2 webinars on Tuesday, December 9th at 8 p.m. Eastern Time on an introduction to orthobiologics and overview of ultrasound-guided PRP, stem cells, and other ultrasound-guided procedures, where we're featuring a presentation by Dr. Taylor North. This webinar is the second session in a three-part series on sports, ultrasound, and orthobiologics, where each session builds on each other. That culminates with a third webinar in this series on Tuesday, December 16th at 8 p.m. Eastern Time, where we're featuring two AMSSM members, Dr. Giorgio Negron and Dr. Robin Patel, as the co-MCs and co-game hosts for an interactive Jeopardy game with case-based and anatomy questions on sports, ultrasound, and orthobiologics. There will be a team competition among some of our charter medical schools that are connected with the AMSSM and SIG. And I also wanted to encourage all resident and medical student members to vote in the election of the 2026 officers for the MSIG and SMRC. This past Tuesday, an email was sent out to resident and student members with a link to SurveyMonkey to access the candidate bios and election ballot that will remain open through Tuesday, December 2nd. Only resident members are eligible to vote in the election of the 2026 SMRC officers, and only student members are eligible to vote in the election of the 2026 MSIG officers. You can only vote once, but your vote is important because often only one vote separates between two candidates. And it has been my pleasure to serve as tonight's webinar moderator. And this concludes tonight's webinar. Thank you all so much for attending.
Thanks for having us. Really appreciate it.
Thank you, everyone.
Thank
Bye.
you, everyone.